area that we serve. And looking forward to 2019, we looked up the number of primary care doctors we need and specialists that we need. And it was a bit intimidating, I would say, the number of doctors that we're going to need to serve the market, even at the 50% market level, market share level. So recruiting is going to be a big deal. I think that was a major takeaway from that meeting is what a big job we have in the way of growing and providing the services that are going to be demanded in our market.
You bet.
I think everybody participated. It was a great meeting. I thought we had a lot of lively discussion. Mine was kind of at a whisper. My voice was gone that night. But we had a lot of good discussion. And I think we got a good handle on the parameters of what the situation is. I think in the next meeting, we need to put some numbers and timetables, and we need to start putting some things into action, because a lot of what we decide needs to be budgeted in the coming year. So I think at the next meeting, we'll need to get down to some hardcore decisions about when, where, and how much at that point. So, but it was a great meeting. I thought everybody did a great job, lots of participation, lots of good information, and lots of great ideas. It was a good meeting, very good meeting.
Thank you. The last comment, just on the CEO report agenda items, is Consolata Healthcare Foundation. Their annual event, Denim and Diamonds, is coming up in just a couple of weeks, August 1st, a couple Saturdays from now. That team, Consolata Healthcare Foundation, is working extremely hard on the hospital's behalf. They are looking for this year's event to be the biggest ever. It actually has the potential to have up to 90 tables sold for the casino night. They're well on their way to accomplishing that. And are trying to raise upwards of $75,000 for the good of healthcare services here in Wilson County. So just wanted to put one more plug in for both the Denim and Diamonds Casino Night. More importantly, just if you know a Consolata Healthcare Foundation member, thank them for the work that they're doing on our behalf. There, I know you've been intimately involved with that. Anything you'd like to add there?
Those folks work very hard. They really do. They're dedicated. They put the effort in, and they will work very hard that night. So if you see one, if you know somebody who's involved with Consolata, tell them thanks.
How many people are involved in Consolata?
There's about 14 on the board, and they need every one of them, quite honestly. They work very hard to put this event together. There's a lot to it. Selling 90 tables, collecting the auction items, and all the things involved, and then putting it all together, taking it all apart. They work very hard. So and they are great ambassadors for the hospital. They really are. So if you see them, come out and support the evening. And if you see one of the Consolata board folks, tell them thanks a lot. They do a great job. They really do.
Could you tell Alton to work not as hard?
I think it'll have the opposite effect.
You can tell.
For those of you who don't know, Alton is what, 78 years old?
Yes.
And he can probably work rings around any two of us. He is the heart and soul of Consolata, and we're just blessed to have him, really are.
And he is persistent.
He is persistent. He's a consummate salesperson. So.
You gave him my number, he called me, I didn't call him right back, and boy, he called me back. He didn't give me any time to.
He had a hot lead, so he was right on it. So.
Has he hit you up, David? No. Oh, give him David's number.
Take that bet, yes, I seem to recall.
I see you guys gotta go David. Another one.
Yeah, he's got a good sales pitch. He twisted my arm through. I bought a table, and then he started looking around my office and wanted to know where I was going to donate it to his office.
Yeah, he does a good job. He does a good job.
Well, this year's event is slated to be the best ever, and like I said, I put a good word into our friends at Consolata. That generically concludes my report for right now.
Okay. We need a motion motion, I think, to accept. We don't need a motion, do we? I need a motion. Still new at this. Next item on the agenda is the CNO report.
Sue sends her regards, but of course, we need to send our sympathy to her. She's dealing with a family matter right now, and she's not able to join us tonight. Our wishes and prayers are going to be with her and her family for a period of time. But I will go ahead and just share the number of thoughts that she wanted to share with you. A couple of items. Number one, we are still waiting to hear from our trauma certification and our stroke certification. We literally are anticipating both of those certifications to come to us any day, but we still have not yet received notification from the state that we have achieved those two levels of certifications. When we receive that, you will hear a big yell. It is something that Sue's worked very hard on and we've worked very hard on. And when we receive that stroke certification, we will be one of 11 rural hospitals in the state of Texas who are stroke certified. So it's definitely something that's helping us to become one of the best hospitals in the state of Texas. So
I'm sure our marketing department is prepared to trumpet that.
yes, they're actually, they've been working on the announcement of that for quite some time. We have some testimonials from some patients who have experienced our stroke care, and there'll be a lot of discussion about that in the weeks ahead. So as soon as we hear, obviously, we will let you know on that. The other thing that Sue is really proud of is that she and Andy Sarala with our emergency department are working heavily on advancing our nursing education. They've been helping some nurses receive certification in critical care. They've been helping some nurses advance their education, as well as doing a number of lunch and learns and other types of activities focused solely on nursing education. I'm probably not able to even give you all the details of what that has evolved, but it's been a project that Sue and Andy have taken very seriously. We continue to advance the level of training and skills of each of our nurses. So again, trying to work towards the idea of being the best hospital in the state of Texas. One of the key areas of that is we met with Dr. Charlie Moorhead, our new pediatrician, about a week ago, and she really spent some time talking about what her needs were from a pharmacy standpoint, from a nursing standpoint, and really sharing some education plans for our nurses to make sure that we're providing outstanding care to her patients when her practice starts here in just a couple of weeks. So nursing education has been a pretty big focus for Sue and the nursing executive team. So I know she wanted to share that with you.
Does pediatrics require a different certification here at the hospital?
For the hospital?
For pediatric care, or no?
No, we've always taken care of children. It's actually kind of a little bit of a misnomer that we don't. That's not accurate at all. Dr. Faulkner in particular does a number of surgical procedures with kids. I think that adding Dr. Charlie's skill set will help us to provide some additional care coming out of our emergency room for patients pediatric patients who need that.
I just recall at some point there was a question about us not having nurses that had pediatric training, or
that was in our emergency department. They were required, or we were moving towards having them all pediatric advanced life support house. So it was part of the process.
Yeah, I think that's
So
a
the
pretty
retreaters
universal now.
they come in distress or whatever. But that training,
It's
done.
Cool. Just two other items. Sue also would report she and Jamie and Bob have been leading a project related to Children's Alliance. There's a situation or an organization in the community that helps endangered children, and Sue has taken that to heart and really has tried to lead some coordination for medical care for some distressed children in the area. fourth item is an item that I'd like to cover a little bit as well. This item, Sue would give much more credence to than I will, but we have worked really hard to bring the strength of the Conley Clinic system, the Conley Emergency Department system, the Conley inpatient care system together to really focus on how well we can coordinate care within the Conley family. There's been a number of conversations about patients will come from our clinic system, maybe they will report to the ER for a certain level of care, then be admitted on the floor for those types of services, and then ultimately be discharged from the floor back to their primary care provider within our clinic system. And what Tom and Bob and Sue have been working on is how can we make that care coordination within the clinic system as robust as it possibly can be. They've added a number of steps, they've added a number of policies and procedures purely designed to help with very effective patient handoffs from one level of care to the next level of care and ultimately back to our primary care offices. So probably another topic that I know Sue would dive into with a lot of detail, but at the board level, I really want you to know there's a lot of concerted effort within the Conley system to make sure that we're coordinating patient care in and out of our ER, in and out of our inpatient unit, and ultimately using the strength of our primary care base within the clinic system.
Is that what we're looking at, making our network talk better?
Yes.
From the whole circle of things?
I think that what we needed to put in place was a number of, we didn't need to put in place, we need to enhance some of the communication processes, but ultimately making some investments in information technology in the future will help make that even stronger. Bob, do you want to address that just a little bit? You were involved in that? Tom?
I think between Tom, it's just about access and communication. It's how we communicate that that person's been here and that we have access to eClinical and some.
Ultimately, we want to be able to communicate across information systems and throughout the community, and even in hospitals in San Antonio that some of our patients may come from. But that's going to take a big investment in information technology. Right now, the transition care process that we're going through, each morning we get a report and we check that report to see who the PCPs were, or the primary care physicians, and then we send those names to the clinic staff, and they then call the patients and try to set up appointments to follow through with their care management plan they got when they were discharged either from the ER, the urgent care, or the inpatient units. And so far it's been working good. For instance, this month we had or this week, we had one of our physicians on vacation, and he had a number of patients that processed through the emergency room. And so what we did was we just routed those patients to the other primary care physician and helped them transition to better health. So, but the IT world is a big area, and there's a lot of improvements we can make, but it's costly.
Are the improvements going to be, do you think, based on our own network, or are we going to be looking at, some kind of, third-party service provider, kind of web-based thing? Well, and of course there's security issues once you go into that world too. So, everything's got a plus and a minus. What are y'all thinking of where we need to head?
Well, we'd like to communicate with the San Antonio hospitals and ultimately anywhere, but that's going to take a lot of coordination with outside areas. We'll need to have interfaces which are very costly, and even talking between the hospital system and the clinic system is difficult. Right now, we are engaged in talks with both those vendors, see how we can get those systems talking together so that we don't have to have a workaround. It'll save time, and it'll improve patient care.
You'll definitely hear more about this in the months ahead. I think the initial project was just to do all we could in our existing system for Sue and the other team members to try to, again, focus on each individual patient and what their needs were coming into the hospital and coming out of the hospital. And then we'll be addressing the IT components of that in the not too distant future.
Is there a common language that hospitals use, or is there a multitude of languages they use, or how does that work? Everybody does their own thing?
Each of the, HL7 is one of the standard interface languages that's used. What we were talking with our group from ICE Technologies, they support our IT department. Really what we have an opportunity to do is put a kind of an umbrella over our systems that has the potential to do what they call an interface engine to force that communication to take place. So that's the type of thing we'll be talking about in the future. When the clinic system started, those interfaces were not even appropriate. We didn't have the scale or the scope. But today, with 30,000 patients coming through our clinic system, we certainly have the opportunity for some efficiency there. Jim?
No, it's just, we're trying to figure that out. And we have to find the method that will work first. And I think we're getting closer to that, and then we can move on.
Is that technology moving as quickly as everything else?
Yeah, that's part of the
problem.
issue. By the time we
Moving
decide
forward.
something else is out there.
Right. Okay.
Spent a few months looking at something, got some old news.
You get lost.
I believe that concludes Sue's report. Please put her family in your thoughts first.
The next item is to review, consider, and take action regarding any of the following items from the Finance Committee meeting. Review, consider, and take action regarding the meeting summary and financial analysis. Has everybody had a chance to look that over? Brian, you're going to go over that? Go ahead.
Jim and I will tag team this, and I think we'll move pretty quickly because I know many of you heard this, but long story short, June was a great month. And there's really no other way to describe it. It was a record month in a lot of ways. For the bottom line, all sources, we had a positive margin of $421,000 for the month, bringing our year-to-date financial results, bottom line, to $2.9 million gain. What's exceptional about June is that our operating gain, which is purely operations prior to any tax support, was $214,000 from operations. That brings our year-to-date operating gain to $1.1 million for the year fiscal 2015. You're going to see in the next couple of slides, we talk about our volumes, we talk about our activity. We set a record for gross revenues. We had roughly $7.9 million, almost $8 million in gross revenues for the month. And Bob, would you run to my office and grab my power supply before we have a real crisis? Anyway, great month. Just all shapes and sizes. An excellent month. The graphs are included in your information packet, but there are a couple that I'd like to point out. In the upper left is our total inpatient activity, admissions and observations. And you can see that for the month of June, we had over 140 total inpatient admissions, inpatient observations and admissions. And that's the highest level that we have had for quite some time. If you look back to about the center of the graph, you'll see June of last year was just under 100 for that same time period for admissions and observations. So pretty excited about that. Thank you, sir. The other big activities take place in some of our other major departments. Number one is in surgery. Surgery had a great month, second highest month ever, with just over 200 surgery procedures. That includes Dr. Hassan's GI procedures, but clearly a great month in our surgery department. Other departments also had significant volume. Lab and radiology were very strong throughout the month. What was really positive for us from a business side, though, was that our ER volume continued to be strong. You can see there we still are hanging out in the 38, 39 daily average for ER visits. But the admission rate out of the emergency department was again also very, very strong. So you put all those factors together, it results in a great month. A couple of neat slides that we like showing. We're obviously very proud of the gross revenue growth that we've obtained over the course of the last couple of years. You can see again June 2009, really June at $7.9 million, truly a strong month, and gross revenue per day at over 260,000, also very strong for us. My favorite slide, next two slides are definitely my favorites. Looking at our gross revenues on a quarterly basis, first quarter, second quarter, and third quarter, as well as fourth quarter, broken out by year, 2011, 12, 13, and 14. You can see that in the last 3 months we set a record, nearly $23 million in overall gross revenues. You know, gross revenues aren't the same as cash. Medicare and Medicaid and our insurance companies, you know, definitely pay us less than what our gross revenues are, about 7% less. But as a measure of activity, this tells us how busy the hospital has been versus prior periods. You can see in first quarter and second quarter, we were hanging out at the $21 million level, and you know, as far back as 2013, for the third quarter, we were in the $15 million level. So definitely, we are in a growth mode as an organization. That's been, I think, pretty well established. Again, looking at all the services that we're bringing on, pediatrics, urology, 2 new clinic practices. We do anticipate continued growth in the months ahead. Here is my new favorite graph, though. This is my new favorite graph. You probably remember from our orientation or other times, we've looked at our blue net revenue line and our red operating expense line. I looked at them as a trend over long periods of time. You remember the first graph I ever did of this went back to 2009, and our red expense line was north of our blue operating revenue line. We've just reconfigured that. Jimmy did this for me just the other day, and I thought it was great. July 2013 to June 2015, the last 24 months, you can see that our blue revenue line continues to grow. We're going to continue to see that in the months ahead. But our trend line for expenses have definitely flattened out. Higher than they were a number of years ago, but we've started to see that point that I've been talking about, where we've built the chassis, we've built the engine. Now we have just variable expenses that are growing at a normal rate, while our revenues are growing much faster than that. So just thought I'd share this one. This happens to be my new favorite.
But a huge chunk of those additional expenses are physicians.
Yeah.
Are new physicians.
Yeah.
Absolutely.
You know, we talked a lot about that in finance, and that, I think you commented in our last meeting, we're going to spend some money. That's the place intended for the quality position. But I think what this graph represents, as much as anything, is that they know that the operation is running as expected. Not a lot of surprises, not a lot. So that affects that separation.
Well, and Ronnie, you led right into the next slide, you know, that I shared with the Finance Committee, I want to share with our board members, particularly the last several months, we have had, you know, 6-digit gains. I mean, we've had a real good run for the last several months. I just wanted to manage expectations a little bit for the fourth quarter. I want to start by sharing with you our budget for the fourth quarter, all 3 months, is really only $82,000. So the operating gain that we were expecting in the fourth quarter is really relatively small for those 3 months. We have budgeted a slowdown in July and August. We hadn't seen that as of the last board meeting, but today's July 15th. The last couple of weeks have been slower. We know we have some physician vacations coming up in the next couple of weeks. We've baked that into the budget. You know, we've baked that into the $82,000, so it's kind of a plus or minus. But we are starting to experience a little bit of summer now, which is very normal in healthcare organizations. What I wanted to share with you is that if you are watching our income statement very closely, our expenses are definitely going to go up in August and definitely go up again in September. We wrote down the expenses associated with each of these new ventures, both in Stockdale, pediatrician, general surgery, and urology. I didn't put any offsetting revenues to this because we know that there's going to be revenues, we just can't really predict it. And just wanted to let you know that we are definitely going to be carrying as an organization some more expenses than we've carried in the past several months. So I guess just be aware of that. We were in the same situation about 18 months ago when our first wave of clinic physicians started. You know, obviously experienced some startup costs, some loss associated with the first months of those practices. We expect the same thing to happen this time, and then ultimately we'll grow into those revenues as those practices mature. So just wanted to let you know that's probably what you can expect for the next couple of months as we run through the fourth quarter. Other graphs, Jim, you want to comment on inpatient?
Our payer mix, it continues, it's not much change from the previous month, 2 months. It's still improved over the historical time. We have better, more payers in our Blue Cross and commercial, which are better payers.
And again, net assets continue to grow, being strong, and cash position also continues to hang out around 90 days cash on hand. So we're pleased with that result. Jamie, anything else to point out on the income statement or balance sheet? Any other thoughts from the Finance Committee related to the financial analysis?
Any discussion? Anybody have any questions about any of that? What was the recommendation from the Finance Committee?
We recommend that we accept the income statements.
And you want to make a motion to that?
Oh, I motion we accept the reports as they're submitted.
Is there here a second?
Second.
Okay, it's been a motion made by James Frazier to accept the report, seconded by Tom Miller. Any discussion? All in favor, raise your hand. All opposed? Motion carries. Next item is to review, consider, and take action regarding the Endeavor quarterly performance fee.
We're gonna talk about this even?
What time flies?
Brian Curtis, and my favorite agenda item for this evening. Brian has his favorite slides. It was reviewed with the Finance Committee. I know David, you weren't there, so basically Endeavor's incentive is to make the hospital perform financially. The board has set a goal for us each quarter to achieve $125,000 profit. It works out to be $500,000 for the year. If we achieve that or exceed it, we get our maximum bonus. If we're somewhere below that, then it proportionally goes down. If we lose money in operations, we don't receive the performance fee. That's how our current agreement is set up. So Jamie has calculated For this fiscal year to date, the 3 quarters you see there, this has been approved by our auditor, and we've been paid the first 2 quarters, and it's now time for the 3rd quarter, which is the number in the bottom right-hand corner. Very blessed, fortunate to be here, appreciate that. It's per our agreement, and we always bring it to the board for communication and for approval.
I think most everybody was here, but were you here, David, in that discussion?
I was
In finance
not.
committee? Okay.
I'm glad that-
The cost of this incentive is already in the budget, so the numbers that we've seen are net numbers in the budget, so we're still at the profitable area or level that we need to be at, so we discussed that pretty thoroughly in finance. Any questions that you might have about any of that?
I think it's pretty simple.
Okay. What was the recommendation?
Bonus, we've done well, so.
Recommendation from Finance Committee?
I'd like to move we approve the expenditure. I'm trying to put this on.
Approve the performance.
Performance fee, quarterly performance fee.
Quarterly performance fee.
I move we approve.
Do I hear a second?
I'll second.
Okay, been moved by James Frazier and seconded by Allison Lambert that we approve the quarterly Endeavor performance fee. All in favor, raise your hand. All opposed, motion carries.
Thank you.
Next item is to review, consider, and take action regarding the urology contract parameters.
Again, just now I want to cover this as an action item. Our market and our medical staff has strongly requested the addition of a urologist to the team. I've met in my conversations with folks, a gentleman by the name of Dr. Naveen Kellogg out of San Antonio, 40-something physician who's interested in coming and participating within our Conley Clinic system. That's an important fact. He's interested in coming here, wearing the Conley logo, being a part of our Conley Clinic system team to provide urology services here locally. He will still have a primary practice in San Antonio, but we've initiated the strategy of inviting them within the clinic system so that we can have some stability with their practice. So he will commit firmly to coming up here 1 day a week. An arrangement very similar to what we do with Dr. Hambrick and Dr. Rimsey. We will pay a small per diem to him to come, but we will incentivize him heavily to produce volume relative to his RVUs, which is relative value units of productivity and indication. I may, in the spirit of negotiation, have to create a small signing incentive to close the deal, but roughly using our standard procedures for the compensation model to entice Dr. Kellogg to join our clinic system on a 1 day a week basis. What's really exciting about this is that when he toured the OR, he was extremely complimentary of our staff. He was extremely complimentary of our equipment. We saw a few things that we probably needed, but he clearly believes that he'll be doing some of his local patients will be receiving surgical procedures here at Conley, which is obviously what we want to have happen. So I'm very positive on Dr. Kellogg. Dr. Nyack, one of our clinic physicians, knows him well and supports him. Dr. Vaughn supports him. And Dr. Profina and Dr. Hassan had the chance to meet him when he came up to visit earlier last week. So I just wanted to share that with you as for your approval to enter into that type of
Just a quick question to make sure I understand. So he will just, he'll have office hours here once a week?
Yes.
So if, I guess I'm trying to wrap my head around how that works. So if he's here, say on Wednesdays, and I start seeing him, but then I can't see him on Wednesday, so I would have to go to San Antonio to see him. So that's like, now that's not in our practice anymore. If I see him there. So, I mean, are we kind of giving somebody a license to come in and get patients from this area and kind of suck them back into San Antonio, or is that any?
I think it is. I think it's a risk. However, I think the good really overwhelms that risk. That's something we're concerned about with everybody. We have a rotating specialist clinic. You know, we have great docs who are happy to have come to our community, but they just simply come and set up their shingle. And if they have a busy day in San Antonio, sometimes they cancel their clinic day here. I mean, that's just part of it. We've started a strategy. We're saying, no, we want you to come, be part of our clinic system. We'll bill for you, we'll collect for you, we'll provide staff, we'll do all of that. But the most important thing to us is that you show up and that you're here on a regular basis. In that example, where a patient couldn't meet with him on the day that he's here, you know, you're probably right. There may have to be some times that schedule doesn't work. But for the most part, what we find is patients who are wanting to see a specialist, we'll see them on their schedule, and it just so happens that that'll be every Wednesday. Actually, it's every Thursday, but every Thursday here.
Do we think that, you know, I mean, obviously, if the volume picks up, do we think we can get him or a different one here more? I mean, what do we suspect the demand for urology services out here? Is it more than for one day a week?
It is. If we use the population ratios, the population ratios say one urologist for 26,000 people, if I recall.
Depends on how many old guys there are.
Right. So our population here is, 50 or 60,000 market share. We're only securing right now 0.2 FTE for a larger population. Here's what we saw with Dr. Hamburg. We kind of set up the same type of arrangement with him. He got here, he started to see the market, and got pretty excited about what the potential is. I'm 80% confident, 90% confident the same thing's going to happen with Dr. Calla. He's going to see what's going on here and actually see that it's easier for him to operate a practice here than it is in San Antonio. A little more friendly, a little more comfortable environment. And if we see the need and he's agreeable to increasing his time here, absolutely we'll do that.
Also, Tom Bryan's done a good job. He's got a 30-day out, so if we see him carpetbagging or sucking patients out, we can address that pretty quickly.
Yeah, because how is he gonna see patients and do procedures in one day? That's, if there is such a need, such a great need.
Well, what we're seeing right now is we're estimating, that you'll see, 10, 15, maybe even 20 patients a day. For a surgeon of his time, if he does that, he'll do procedures in the morning and see patients in the afternoon, and that pace is pretty comfortable for a physician like him. So theoretically, he would do a number of procedures in the morning and then see his patient base in the afternoon. And depending how big that gets, obviously we can make adjustments.
Are we set up for that? Okay, it's not. See, urologist every 3 months. I'm that age. And, part of the procedures are robotic anymore. Are we set up for doing that kind of stuff?
No, he would recognize that, and we recognize too, all the robotic stuff, go somewhere else. That's not a service that we're currently able to provide, and certainly even willing to entertain at this point because it's extremely costly. But he shared a number of procedures that he felt extremely comfortable that could be performed here without the need of robotics. The robotics is a very nice to have thing that a number of surgeons value, but also they recognize that it's not a necessary thing.
Where is his primary practice?
Down in the medical center area.
On the north side.
Is he part of another group?
No, he is establishing a new practice called the Urology Place, I think, something along those lines, and he's establishing a new independent practice.
That's good.
We're talking about a specialized practice too. about the only thing I can think of he's gonna be able to do here would be biopsies. Personally, I mean, what other kind of procedures is he gonna be able to do here?
Well, I know he talked about cystoscopies, some of those types of initial examinations are definitely.
Sling procedures on females, you can do TURPs.
Yeah, we're already doing, we have a physician doing terms here already.
Not everything's done or legally.
Vasectomies?
So if we have a demand, if our population has a demand for two, right?
Yes.
Understand, right? What is our strategy, because our history and our experience is that when we offer the service, they come and they trust us. So what is our strategy on going from that 1 day a week to we will probably have a need for, or demand for a full-time neurologist in a short period of time. How will we transition into that?
Let me kind of address that directly. Number one, Dr. Kella is completely open to expanding as the need is there. The reality is that he sees that money is here now, but he wants to test that market. I mean, and I think that's a fair statement. So, number one, he very openly says, "Hey, Brian, if we need to go more, we're going to go more." So, yes, kind of the first step here is I recognize that everyone will say, "Well, let's go get a full-time urologist," because that's what the market will bear. We've got a hot candidate who's interested in testing the market and then growing. So that's step one. Step two, and I maybe should have mentioned this a little bit earlier, he has also stated to me that his recruitment plan for his practice is to add another urologist sometime in the not too distant future. Not in the next 6 months, but in the next year, maybe 18 months. So I think that we have a couple of opportunities to increase the capacity here when we see that the capacity is to increase.
I don't know. One of the strategies, if this doesn't work out, is you need to contact some of the big associations that have like 30 or 40 physicians, because they're, people I see, they have satellite offices all in Bernie and south side of San Antonio and a couple of, Stone, but their main business is where they do their surgeries and stuff is down at the medical center. What's the chances of recruiting one of those bunches to send a physician here and make this one of their satellite offices? I'm talking about urology of San Antonio.
Those strategies are not foreign to us. We like to find good partners who will commit to our area to grow with us. What experience has shown us here is that we've had groups come and be interested for a period of time, and then when it starts getting slim, for whatever definition that is, then their commitment wanes and we don't have the control. That's what we've seen for a period of time.
I can also see that you got that problem too, where they're cycling off the hospital and they've got their own labs and that kind of stuff, and they're probably not gonna be using facilities here. They're gonna be using their own facilities because they do have the robotics and
the strategy that we're pursuing, maybe we should even separate this conversation and take it down an oncology route. Oncology would be a good place to find a partner to come and to strongly develop a program here. But urology is one of those areas that if we link it to our clinic system, and make it ours, then we have the potential to control a little bit better. And that's really what we're trying to do here with Dr.
What was the recommendation for the clinic?
Finance Committee recommends that we accept this proposal.
Any,
We're are we recommending that
Uh,
give Brian authorization to pursue? Is that what you need us to recommend?
Take action regarding the contract plan. Any other discussion? Do I hear a motion?
I'll make that.
Second.
It's been moved by Tom Miller and seconded by Ronnie Eckel that we give Brian the authority to work the contract. All in favor, raise your hand. All opposed, motion carries. The next item is to review, consider, and take action regarding the press, is it Janny? Patient satisfaction report. Right.
Just real exciting to report to you that I need approval to extend a bonus to our employees for the second consecutive quarter for achieving our goals in patient satisfaction via press ganning. We have a hospital policy in place that if we achieve a certain level of performance in our patient satisfaction scores, that our employees receive a $50 bonus. And we want to recognize that, once again, we've scored in the top 5% of the nation for press ganning surveys in April, May, and June of 2015. You remember last quarter, I came to you and said for the first time ever we had achieved that level of performance, top 5% of the nation, January, February, March, and we, through the efforts of Bob, through the efforts of Sue, and through the efforts of all of our employees, repeated again with top 5% of the nation performance in terms of our press ganning scoring. So I'm seeking approval to expend about $7,700, something along those lines, in $50 bonuses for our staff.
Recommendation from Finance Committee.
Yeah, the Finance Committee recommends the board to approve this bonuses for the employees.
Do I hear a motion?
So move.
Second.
Okay, it's been moved by Ronnie Eckel and seconded by Tom Miller that we approve the press Yanni patient satisfaction reward. All in favor, raise your hand. All opposed, motion carries.
Thank you, and we will obviously announce this at Open Forums, make a big deal of it, we have a lot of fun, and we recognize the board for supporting the employees and their accomplishments, so thank you for doing that.
There's been a lot of good news tonight, but that's a very significant accomplishment. 95% of our peers are worse than us the last 2 quarters in patient satisfaction. They work very hard.
And we reward quality, so that's great, that's fantastic. Next item is capital budget review and purchases, the North Campus renovation.
Just want to clarify a couple of things here related to our North Campus project. A number of months ago, a couple of quarters ago, we came to the board with our April of 2014 budget estimate for the North Campus project. At that time, April of 2014, we estimated the project was going to be about $250,000. We had an actual estimate produced by a construction company. You probably recall that over the last few months, we put that out to bid. The first round of bids came back significantly higher than we anticipated. We rejected those bids and put the project back out for a second time. We had stronger competition in the second phase of bidding, and came back with a ultimate winning bid of $364,000 and some change there. I'm seeking today approval of the overage, but I want to explain it to you before I request it. Number one, again, our estimate was based on April 2014 estimation for construction costs. And I feel if we put any type of inflation factor on it when we requested it. But more importantly, the scope did change just slightly. That had a difference. We originally designed or originally thought that the project would take the second half of the North Campus and make it a separate clinic with a separate doorway in the entrance. That was what the original estimate was based on. But ultimately, we elected that combining the reception area, combining the waiting area was a better plan. That's going to require a minor amount of renovation to the existing clinic there to make it a single clinic on both sides. And that scope change drove a portion of the average here. So between the two things of just an old estimate that wasn't inflated and a minor scope change to expand the reception area and make it a singular reception area as opposed to two separate clinics, that's what brought us into the ultimate winning bid of $364,000 and some change.
Is it gonna disrupt Dr. Peterson's practice at all?
Disrupt, anytime you have construction, we're gonna have disruption. So, the short answer is yes. But the renovation work, the front office work, they're designing a way to access the space that allows them to do construction without being right in everyone's face. And secondarily, we're going to try to minimize that the best we can. The short answer is yes. They're going to do some of the work in early morning hours, some of the work in evening hours, and try to minimize, the clanging and banging during patient care.
You start floating and taping and sanding, that dust goes places you can't even imagine it would go. And then paint, it's going to have strong odors.
They'll seal off. They'll seal off. 90% of the project, 85, whatever. 90% of the project is able to be done without, penetrating walls or anything else. It literally is a virgin area. Doesn't even have a floor in it right now. So 90% of the work can be done without any problems. When we get to the reception area, that's where they'll be